So each year, Carmen has me present on something that we're both passionate about. And the issue comes up very often in treating kids with SM. What's the appropriate role of medications? And I had the honor of being the moderator for the expert panel at the end of the conference a couple of weeks ago, at the end of the day. And so the first question I posed to people was, what's different about your practice related to SM now compared to when you started in the field? There were 9, 12 experts on the panel, and 201, everybody talked about making treatments more intensive, specifically about adding medications more quickly in the process. None of those people are particularly lovers of medication. None of them, to my knowledge, have significant stock in a drug company. So there's no secondary gain for people like us to be promoting medication. So this morning is a chance for us to talk about the appropriate role of medicine, the talk title, they shouldn't have to work so hard, the appropriate role of medication in the treatment of SM. And when we say they shouldn't have to work so hard, you as counselors, you as parents know, and some of you wearing both hats as counselors and parents, you know these kids work their buns off. It's really, really hard. It ain't easy. And they are kids, so they have kid think. They don't even have adult think to bring to it. So if I was suffering from tremendous public speaking anxiety, this pushing myself would be something that cognitively I know why I'm doing it. I can weigh all the pros and cons cognitively. But the typical kid we treat is below the age of abstract reasoning anyway. So they're not even able to do that cognitive pros and cons. So I don't think kids should have to work that hard. And not every kid will end up on medicine, but it should be an option that we talk about. I have no financial disclosures. I don't stock in any drug companies. I'm not paid by any drug companies to do presentations. But I have other conflicts of interest that I do want to disclose, which is that there's nobody more invested in developing behavioral treatments than I am. I have 4 letters after my PhD, which is that I'm board certified in behavioral psychology. There's nobody more invested in developing behavioral treatments than me. And still, I'm not able to be God's gift to overcoming selective mutism to every kid, and I'm not able to do as quickly as I would like for their sake. Why should it take so long when every day they are experiencing some kind of being shut out? Yesterday I was giving a talk on child anxiety, and the keynote was a fabulous woman talking about a technique where kids are encouraged to do, in preschool, encouraged to do acting out with their peers. And it's predicated on the kid dictating a story to the teacher, and then everybody getting a role. And so I'm sitting there as the SM guy in the audience thinking, great, another opportunity for the kids that I call patients with SM to feel excluded. Not that the teacher would do anything to exclude them, but the kids that we're talking about aren't ready to participate in that. So they're going to go to school and have yet another experience where they feel left out until we get them the help that they need. My other disclosures, I'm heavily invested in getting kids better. That's what we do. And I think our field in general has gone more towards intensive treatments. Carmen and I had the honor of presenting a very long symposium on intensive treatment. It's actually available as a DVD on the website, for which we get no royalties on the ADAA website. And it was a good presentation. I think we captured all that we wanted to. So we're invested in getting kids better. And not just a little better, but really better. So for me, a little bit of improvement on a rating scale like the Selective Mutism questionnaire from 0.8 to 0.95 or 1.3 still leaves kids impaired. So what do we know? We know kids with anxiety disorders, kids or even all disorders, typically have more than one. It's just the nature of how disorders happen. So 55% of kids have 1 diagnosis, but 22% have 2 to 3 diagnoses. Specifically among child anxiety disorders, it's rare to have a kid present with 1 diagnosis. Most kids will present with 2 or more. And in part, that's because in DSM-4 and now DSM-5, we carve the anxiety disorders into 9 different boxes, but it's one central nervous system. It just happens that we sort of look at the phenomenology of, so you're separation anxious, but then you're also phobic and you also have some social anxiety and you have SM. So it's sort of an artificial distinction. It's not like they're necessarily more sick because they have 3 diagnoses. It's just the way we kind of describe them. But within SM, and this has been borne out time and time again, the most common coexisting, co-occurring comorbid diagnosis will be social phobia or anxiety, avoidant disorder. This goes back to a couple of different versions of DSM, and that's why it has different names. But it's basically the most common co-occurring disorder will be social phobia. Just picture in the mind's eye that you have kids with SM who are happy to come up and dance, happy to come up and play the fiddle, happy to come up and present a show and tell without words, and kids who are deer in the headlights on the playground, not otherwise engaged with their friends, not willing to come up and do the ballet, not willing to stand in front of others and get their picture taken. So you can have SM with social phobia and without. And they'll require different treatment from us. But other things happen in relatively low percentages. Interestingly, ADHD, attention deficit hyperactivity disorder, is actually at a lower rate in kids with SM than the general population, except for the lovely lady I met in the back who's got the double whammy. If you think about it, if you've got hyperactive impulsive type of ADHD, it's sort of hard to keep your mouth shut, right? So it's an interesting sort of co-occurring thing. So what do we know about treating child anxiety disorders? The biggest, largest, longest, most well-controlled study that you can go to in the research, the one that you as grad students should know about, the one that you as parent consumers should know about, is called the CAM study, Child Adolescent Anxiety Multimodal Treatment Study. It's for now, the gold standard study. They treated kids 7 to 17. They had upwards of 500 kids, 448 kids. And there were 4 treatment arms. There were kids who got expert CBT. There were kids who got an SSRI, which is a selective serotonin reuptake inhibitor kind of medicine. That's both an antidepressant and works for anxiety. Kids who got the combination and kids who got a placebo of the medication. And mostly the diagnoses included separation anxiety disorder, generalized anxiety disorder, and social phobia. There were some kids who had selective mutism as part of the picture, but they weren't primarily the kids recruited. But there wasn't, at this point, any randomized controlled trial specifically working with kids with selective mutism. So this was the closest thing we had to draw from. And by the way, for those of you here, those watching online, my presentation is available online, so you can have the PowerPoint. And, we'll provide my email later so that you can access that. In the study, 60% of the kids who got just expert CBT, when I say expert CBT, I mean by people who were super well trained to do it. Every session they did was observed by experts in it, so they really kept on their mark. 12, 16 weeks out, 60% of the kids were doing significantly better. Not bad. For the kids who got medication alone, 12, 16 weeks out, 55% were doing significantly better. So if you're a parent and you've got to decide, if you knew this ahead of time, should I go with CBT or medication, all other things being equal, you'd say CBT had a slight edge. The kids who got the combination, 81% of them got significantly better 12, 16 weeks out. I'm saying 12, 16 weeks because I'm actually forgetting just at the moment which it was. But that's 3 to 4 months. 23% of kids were placebo responders. That means even at 12, 16 weeks, people blind to whether they got the medicine or not actually rated them as significantly better. That's how strong the placebo effect can be with anxiety. You would not see that in ADHD. Parenthetically, you don't get a placebo response 3 to 4 months out. So now if you're a parent, you've got a tougher decision. Because your odds, 60%, 3 to 4 months out, not terrible odds, but 81% is better than 60%. Now, we're having this discussion in part because I would assert to you that there are risks for undertreating this disorder. So every day of a parent is not neutral. If your kid is in the preschool class that I described before, then when they go back to school on Monday, and this is something they do every day at their school, It's Monday, you're gonna fail at being a participating member of your community. And I don't like that for kids. Every day not only is not neutral, but it actually strengthens the habit of avoidance. So let's pretend for a minute that you're all selectively mute, and I go around taking roll call. Every time you don't answer me, that habit of not answering me gets strengthened. It's different than if you're a snake phobic. Are you a snake phobic or not? You're shaking your head no. Are you a snake phobic or not?
No.
No. Good answer. If you were a snake phobic and you didn't encounter any snakes today, the habit of your avoidance would not be strengthened today. It would only be strengthened if I presented you with a snake that you avoided. But we know that our little guys and gals who go to school don't have an option to not be having prompts to speak. They have it, unless you're going to suppress them at home. Every day that your child goes into the community, every day that the kids we work with go in the community, the school, the bakery, the deli, the library, not only does their habit get strengthened, but others' perceptions that they're the kids who don't talk get strengthened. If you've done this work long enough, you've had the experience that I've had many times of being told by a peer, oh, mister, that's the kid who doesn't talk. The most painful time I remember was having worked with the first kid I ever worked with SM, and I went with him on his first day of first grade. And every first day of a school year, you only get to go with one kid. So it's a very exciting opportunity. So we practiced in the hallway what we would say when we got to his desk, got up to his desk, and I asked him a question. The kids' desks were like 2 by 2. And just as I'm asking him the first question, the kid over here facing him says, oh, he doesn't talk. That kid is now off at college. He's a pilot. You can only be a pilot if you talk to the tower, so he talks to the tower. He got a 50% scholarship based on grades and then competed for the presidential scholarship, which required him to go up to the university, and in a room with 50 faculty and parents, he was given 15 minutes to prepare a speech like all the other people were. And they could only write their speech down with bullet points on an index card. They were given one index card. So kids can recover, right? And that should be an optimistic story. But being with him on the first day of first grade when this gal said to him and to me, he's the kid who doesn't talk, it was very painful. And it may be demoralizing. Little guys, 4, 5, 6, 7 won't come to you and say, I'm feeling demoralized or depressed, but it can't be good for one's sense of self. And it certainly decreases self-efficacy, which is different than self-esteem. Self-efficacy is the degree to which you believe you can actually do something. So the degree to which I think I can stand up in front of 15, 20 people I haven't met and give a talk is self-efficacy. And the long-term risks of undertreating are humbling, because long-term undertreated anxiety disorder puts people at risk, unfortunately, for all these things. A higher rate of school absences, because as you get older and you get more severely anxious, avoiding is very reinforcing. Underachievement, impaired peer relations, substance use, maybe self-medicating, some people think that's the reason. Difficulty adjusting to work situations because there's a lot of demands to interact in work situations, and anxiety disorders into adulthood. So we care a lot about getting adequate doses of treatments. If you take a medicine, we're used to thinking about adequate doses of medicine. You all know that if you're given a 5, 6, 7 day course of antibiotics, that even if you feel better on day 3, you know you're supposed to keep taking the antibiotics. A lot of people don't do it, but they know that they should. If you had a headache, how many Advil do you take?
I don't really take medicine.
Okay, so we got a 0 there.
I would take one Excedrin.
1,
Just one.
1,
2.
2. Raise your hand if you're 2. Raise your hand if you're 3. Raise your hand if you're 4. There's usually one liar who takes 4 and just doesn't like to admit it. That's true. But it's a small enough group we may not have a 4. But we see quite a range in dose of what a person would take for headache. I'm a 2er. So we have from 0 to 3 here today. So we can look at doses of behavioral treatment, and we're not sort of, I don't think many of us are used to think about it that way, but it's I think a good way to think about it. So there's no treatment at all. That's the no headache medicine. There's not enough treatment, and there's high dose robust treatment. And it's important to sort of gauge where you think treatment is at. So no treatment looks like this. Here's a girl who came to us when I was at one of my previous institutions, I think back in my NYU days. And she looks pretty impaired on this thing that we call the Selective Mutism questionnaire. Her lines, her scores are the blue bars. And she looks like getting much lower scores than the average kid with SM and then kids without SM. So she's a pretty impaired little kiddo. And at the time she was diagnosed with both selective mutism and separation anxiety. I happened to catch up with her years later when she'd had no treatment, unfortunately. And she was still significantly impaired and now had 2 more diagnoses. She had, in addition, specific phobias and social phobia. At the time I made this slide, she had not received any treatment. So for me, this is a typical course of no treatment. Lindsay Bergman did some research when she developed the SMQ years ago and looked at kids' teachers' ratings 6 months later. A bunch of kids had slightly lower ratings, but they were still in the impaired range. So no treatment makes no sense. And this is a good example of no treatment a couple years later. Fast forward, this kid has now come back to me, to my group for treatment a couple of weeks ago, for treatment for her social phobia and specific phobias, but her SM was successfully treated after they came in at this point. And working on her fear of thunderstorms is a relatively easy thing to do, and the social phobia is responding very nicely to treatment. Not enough treatment would be reflected in this kind of case study. I worked with a 6-year-old girl. She spoke to parents easily in our clinic, spoke with me fine in the room, quickly started talking to me. We went to her classroom, and we used to go in the morning before kids arrived. We were lucky to have about 20, 30 minutes. And as soon as kids came in, as they do in the morning, like typical kids with SM, she stopped talking. But the inadequate dose of treatment is reflected here, that we're 23 sessions in, and every time is the same thing. She's talking to me and mom fine in the classroom. Teacher could be in the room, but as soon as we worked to get mom going out at all, she would completely be unable to continue to talk. 23 sessions in is not okay for me. That's a lot of hours. It's a lot of time. It's a lot of money. It's a lot of not getting better. So it was with this kid that I started thinking about benchmarks for treatment. Like, what do we expect kids to be doing by the time we spend a couple sessions with them? If we look at high dose, robust treatment, this is our first cohort of kids who went through the Brave Buddies program that I created first at NYU and then brought to Child Mind. And we see in the course of the Brave Buddies experience and then getting even better at follow-up, kids can get better. So we look at dosing of treatment and say that we can give different and better doses of treatment. Not every kid will respond enough, but that's the best we have to offer right now. So when we think about which kids should get medicine, we think of some factors like, if you're 23 sessions in, what are you going to do to make the treatment more robust? So kids who are really not responding to treatment at an expected rate, and this is a discussion as therapists we should be having with parents at the very beginning of treatment, what they can expect. So I'm telling parents, 2 to 3 sessions in, most kids will be talking to me just fine in the room, and you're already on your way out. Next week at ABCT, one of my former students will be presenting a paper on a single case study we did where parent was out by session 3, and kid was answering 100% of our questions by session 6 with the parent out of the room. So kids who are not responding at an expected rate or an acceptable rate, or at a rate that's making them feel confident. If this treatment is working as a behavior therapy, every session kids should feel like they're moving closer. It shouldn't be that it takes weeks and months before they get a sense that they're progressing. In football, it's called forward motion. Guy gets the ball, and as long as they're going forward, the play doesn't stop. They could be inching at this rate, and the referee doesn't call. It could be one play for the whole game. If they can keep going and nobody's tackling them, the play doesn't stop. That's forward motion. That's what it takes for a kid to be confident, and we want to make sure we see that rate. They should be feeling good about the process. Very few kids dread the process. They should look like they're feeling relieved. They should be indicating to the parent they're feeling good about it. And they should be feeling that it's efficacious, that they're the ones having an impact on their progress. So what are our benchmarks? We looked back after this very frustrating kid for me and started gauging what kids should be doing. So by a few sessions in, kids should not look angry. They should not look like deer in the headlights. They shouldn't be frightened at the start of sessions. By a few sessions, progress should be obvious, even if it's this forward motion. By 2 to 3 sessions, kids are usually easily talking to us in a room with the parent present. And by 4 to 6, they're talking to a therapist with the parent not in the room. They're not looking to see if the parent is there. They're frozen. By 4 to 6 sessions, the vast majority of our patients are responding nicely to the behavioral treatment. By 6 to 8, we are doing in-school sessions. Most are talking to an adult without the parent present in the room. By 8 to 12, most kids are talking to some combination of other people, places, or activities. Either we faded in another peer, we faded in a teacher, we moved ourselves away while 2 peers came in, some combination of that. Any questions so far on this or anything that I've been talking about? Any online?
No, not yet.
So we, in our practice, are unlikely to medicate kids who have less severe impairments, who've never had a trial of cognitive behavior therapy or behavior therapy in the past, who have low co-occurring conditions, and who are meeting the benchmarks. And the family history isn't so strong. I actually just moved this down to the lowest one, because it's really not the thing we take into account the most. And this is likely to be a younger kid. When I say younger, I mean 7 and younger. By the time we get to meet 8 and 9-year-old kids with SM, they're a different bunch. They're harder to treat. Because unlike other things, unlike, for example, OCD or tics, which won't come until later in child development, like 7, 8, 9, for many kids, the child who presents with SM at 7, 8, or 9 is the same kid who had SM when they were 3, 4, 5. They've just been practicing the habit for a heck of a lot longer. We're more likely to medicate kids with more severe impairment, kids who've had a poor prior response to what we think is a reasonable treatment, kids who have other comorbidities that are also getting in the way, and they're not meeting the benchmarks and have a strong family history. This is not a rigid decision rule. It's just relative factors that we take into account. But most important thing that drives the decision for when we go back to the parents to talk about medicine is, are the kids getting better and are they still impaired? Because it shouldn't have to be so hard. Any questions, comments?
It sounds like, at least the data that you're looking at, that families were pretty well evolved. In the groups that I work with, there's a lot of other things going on. Typically, families are, the parents speak another language, homelessness, or they may only have one parent who is also severely mentally ill. So would you adjust then some of that thinking, given those criteria?
I would adjust what I do differentially on each of those. So for the family where English isn't a primary language and I'm limited being an English speaker, I want to bring in people who can translate, not just try and fake it with whatever little Spanish or little other languages my people may know. Where there's other psychiatric illness in the parents, I just want to do my best shot at talking to them about how impairing psychiatric illness can be. And that's usually not a hard sell. What were some of the other sort of co-occurring?
Homelessness.
This is a difficult thing to, let's assume for the moment that we can get care to the homeless family. This is a very labor-intensive treatment. So I think the medication won't be any more complicated to work out with a family that's living in shelters than the other parts of the treatment. Actually, the medication will be easier to do. We are at the point that when we see kids with this combination and we want to bring on medicine, for some of these kids, we're actually wanting to do medicine before we even start the behavioral treatment. If I get a 9-year-old who's already failed a prior attempt at a reasonably good treatment, who's so impaired that they're wetting themselves at school, not eating in front of others at school, not seeing friends outside, I want to get that kid medicated before we start behavioral treatment, just because I want it to work, to go a warm-up exercise. So not only are we more likely to bring medicines on board for some kids, we're also making clinical decisions about which kids we would actually medicate before they start the behavioral treatment. Because the last thing that you need for their batting average or your batting average is another failed behavioral treatment. And I say CBT here, I should probably change it to what I think we do, which is just behavioral treatment. I just got a paper accepted to present for next year's anxiety conference called Who Put the C in the CBT, because the younger these guys are, the less cognitive work we do. So it should be a fun talk to prepare. It's a good thing I don't get anxious preparing. So I should go back and say how to start medications. The first time that I should be talking with the parent about medicine is when I do my feedback session, whether or not I think the child is headed down the road towards medicine or not. Because I owe it to them to sort of talk about all the ways the treatment could work out. We could luck out and your kid could be a great responder to the behavioral therapy right away, and that's awesome. And then we don't have to consider medication. On the other hand, despite the fact that you're doing what you can, and I'm doing what I can, and your kid's doing what he or she can, they're just not responding as well as we would like. And I'm going to want to revisit the issue of medication with you after a certain amount of time. So I'm curious, we have grad students, we have professionals, what do you think a reasonable amount of time is, based on everything you know? If the parent is doing their homework and you're doing reasonably good therapy, how long do you think it should take before you revisit the discussion of medicine because they're not responding well enough? Let's just kind of take a survey here.
5 sessions?
5 sessions?
Yeah, I was gonna say around the time where they should start meeting those first or second benchmarks. Maybe
Okay.
and evaluate, so like 4 to 8.
Okay, 5, 4 to 8,
That's it.
4, 5, 6, 8.
The parent.
That's okay.
As a parent, I would have said 2 to 3 months.
2 to 3 months. So parent, for a variety of reasons, may have a different calculus on this.
My girl started on Zoloft prior to treatment, being in the field, and seeing the efficacy of medication. I was pro medication before starting to see if we could lessen any of the anxiety to see if treatment to start would be more effective.
So as a parent of young kids, you made decisions to start medicine even before the trial of behavior therapy,
Yeah.
based on everything you knew.
They were 4 when they started on
Never
Zoloft.
before. Were you assuming that they might be able to respond totally to medication without behavior therapy?
No.
The answer is no. There are actually very few people who will treat with medicine only. But somebody who wrote a couple of the classic papers that we use in the field, a guy named Steve Dummett, who's a psychiatrist in New York, he'll treat kids and tell parents they're probably going to respond to medicine only. Now, I don't know if they will, but he's not an unwise, unscholarly guy. He's written some classic papers mentored by some very good people. So it's not a crazy thing. But you'd be an outlier among parents I would meet who would start even before a first round of
And I
treatment.
think
With good reason.
I have a different perspective too, because they had already been on, they take Ritalin and 10X as well for their ADHD, which they started on at 3. So to add another psychotropic, I was like, okay, let's do it, whatever.
We have outliers on both ends, and you were ready.
Might as well.
You don't get to vote yet.
Are we assuming a regular child or one of those conditions that you talked about for more, where there's more impairments?
let's assume a typical kid that we will meet, whose response to treatment you don't know. So the question is, what do you tell the parent when you do your feedback session and your treatment planning about when you're going to want to revisit that discussion if they're not adequately responding to the behavioral treatment?
Well, they're on the content.
Probably around
Or-
8 here.
4 to 8 sessions.
4 to 8. Notice what good reflecting I'm doing? Better, I'm the guy. Carmen, what do you tell parents in your initial feedback?
I usually say about a month. Let's go with a month.
Okay.
And see how you do.
So a month would be on the shortest end. 2 months would kind of be on the longer end. But the idea is to have that discussion with parents before they have a sense that they and their kids are failures at this thing called treatment. And so you've sort of presaged that we may need to go there. Now, when I write a contract with parents who are coming in for intensive treatment, or I'm going there to their homes for intensive treatment, I put in that outcomes are unpredictable, but largely related to how well the parents follow up on our recommendations and do daily practice. And as of this year, and some of you who are here haven't seen it yet, our online audience hasn't seen it because I'm presenting it for the first time next week at exactly this time. We have a treatment tracker that we're using, and one of the graphs that has a lot of real estate on our treatment tracker is how many exposures did the parent do during the week, and how many new persons, places, or activities was the child able to be successful in. And those two are on the same graph, because if you keep doing exposures, your kid should get better. That being said, if we're 2 months into treatment, I want to revisit that discussion with you. So how to start medications starts with that discussion when you have your feedback session. Because although you can gauge, is this a mildly impaired kid, a moderately impaired kid, or a severely impaired kid, you can't predict at all their response to treatment. Group, and those of you who graduate students, you really want to remember this. Group data tell you about groups of people. They tell you nothing about an individual. So if I have a point on a graph here, 50% of the population that you're studying is below that point, and 50% is above. If I do, you have a permanent marker so it can write on your wall? If I do a graph of ADHD symptoms over time, over development, you'll see that they kind of wane over time in the teen years to the hyperactive impulsive symptoms. But in that waning, half of the population of kids with ADHD will be above that line and continue to be impaired, and half aren't hyperactive or impulsive at all. They can sit through a meal, they can let you talk on the phone and get a whole conversation in. God bless, the day will come, you can talk on the phone, you can go to the bathroom uninterrupted. So, how to start medications doesn't start with how to write a prescription, it starts with the discussion you have in the feedback session. And by the way, who do you think has better kind of selling power, if you will, to talk with parents about medication? A well-informed psychologist or a well-informed psychiatrist? Even though psychologists, at least where I practice, are not prescribing per se. Psychologists, because we have less of a vested interest in using medicine.
We usually have a better relationship to them, so.
That I'm not sure. I know some psychologists who have terrible relationships, and psychiatrists have
Well,
great.
because you're in the East Coast, I'm in the Midwest.
We've already had our Midwest East Coast contrast. I had to go invite these people to come in from the waiting room, the East Coast. They take over the room. Okay. American Academy of Child and Adolescent Psychiatry has chimed in on this. They say first consider CBT. That makes good sense. That's not contrary to what you did because you considered it. You just decided to do something else.
Well, and they, at the time were 4, and so I knew that, their abstract thought wasn't there.
Yeah,
be
they
able
weren't
to
going
do
to get
that.
much C in that CBT.
So, right, so
Yeah.
we weren't gonna get very far in,
Yeah.
and then with the family history too of anxiety, so.
Within medicine, SSRIs are the treatment of choice. So again, selective serotonin reuptake inhibitors. The first generation were not selective serotonin reuptake inhibitors. They were non-selective. There's no specific medicine designated for SM. There's no randomized controlled trial on a medicine. It's that class of medicine people look at, and looking at the risk versus benefits, looking at the risk of not medicating, the risk of medicating, and again, there's no one SSRI that's consistently better than another. So the axiom used by my psychiatrist colleagues is start low and go slow. You have a question or comment?
About the medications, are there medications that are not suggested to go along with treatment?
That's a good question, which is, are there medications that are contraindicated? Basically, no. But if you're using anything other than an SSRI with a kid who has a primary diagnosis of SM and another anxiety disorder, one would want to know what the thinking was that got you there. It would be like starting a kid with ADHD, not on a stimulant to begin with. So what psychiatrists generally have is my first line medicines, my second line medicines, and my hope we never get their medicines. I'm working with a kid now, and the psychiatrist is a good friend and colleague. He blew out on 2 stimulants for his ADHD and anxiety. Blew out meaning only side effects, no main effects. He's been a not very great responder to the SSRI he's on. My voicemail that came from the psychiatrist yesterday was, parents know that if we restart this other medicine, it's irrelevant what it is. If we restart this other medicine and it doesn't work, I've had the Risperidone conversation with them. So to go to Risperidone, for a kid with anxiety and ADHD, you have to have gone through some other things. Otherwise, it's malpractice. Nobody would get there without a good reason. So start low and go slow. Because when you start low, you can kind of pull for the side effects, which might come first. You're first likely to see side effects before you see main effects. This is a good thing. And if properly prepared, parents know that if they see side effects, it's likely to be what we would call, in quotes, nuisance side effects, meaning they're not terrible and they go away in a couple of weeks if you just kind of hang in there. Now, easy for me to say just hang in there as you're having maybe some GI symptoms or headache symptoms or being a little bit disinhibited in the wrong kind of ways and poopy and booty and other kinds of inappropriate things for that child. So it's easy for me to say just hang in there, but we encourage kids and parents to do that. Main effects might be seen as early as a couple of weeks and then take a little bit longer to get up to therapeutic levels. What's really interesting in terms of the first week is you can see some loosening up of the kids generally. I think you described it as people could see the sort of body language was just a more relaxed body posture. That wasn't the reason these parents would have treated those kids with medicine, but it is what you see first in many cases. So it's a nice precursor of what may be coming down the road. But I got an inquiry from a very close SM colleague in Vancouver yesterday. She said, do you think in 2 days I could already be seeing its effect on SM, or do you think it's placebo? I think it's placebo, as best I can guess. And then you see specific effects and the ability that we're going for, the ability to tolerate exposures. The reason we want these kids on medicine is so that they can do the behavioral exposures that we ask them to do. How do you decide which SSRI to use? Again, there's no specific indication for one over another. I asked a parent in the audience today, how did you and the doctor decide Zoloft? The answer, as is typically the case, is somebody else in the family had an anxiety problem and they responded well to Zoloft or better to Zoloft, so they went with that over Prozac. Where I come from, most people will start with Prozac, but there's no literature to suggest doing that. And importantly for the psychiatrists who may watch this or who you work with, this is all off-label. Most psychiatric medicines for kids are used off-label, meaning there isn't a specific FDA approval for that medicine for that condition. That doesn't mean it's malpractice. It just means that the studies haven't been done to say this has been shown to be super effective for this condition. And FDA understands that, ACAP understands that, parents tend to understand that. So a family history of a good or bad response leans a prescriber to or away from a specific medicine. Phenomenal range of doses, which is why the internet is both fabulous and terrible, because people start comparing doses. My kid's on 0.5. Right. Is your kid on 0.5 milliliters or milligrams? Because 0.5 milliliters is actually 2 milligrams. Oh, my kid's on 80 milligrams. Is my doctor crazy? There's such a big range from a couple of milligrams all the way up to 80 milligrams. Just like there's a big range from 0 Advil to 4 Advil. It's a very, very wide range. So we have to help parents understand to be cautious about doing comparisons to other kids. Every brain is a little bit different. This is more of interest for getting the handout and just having something to look at. There's nothing here clinically that's worth our taking time to talk about. There's a whole bunch of different medicines, and this slide is a couple of years old, but I don't think has anything outstanding that's been shown to be inaccurate at this point. Prozac is the most common one used. People will vary in how quickly they'll go to a higher dose. What's the danger of going to, not the danger, what's the sort of intellectual risk of going to a higher dose too soon?
You don't know if a lower dose would have been as effective.
You don't know if a lower dose would have been as effective. That's absolutely right. So if I put you on X today, and then in 2 weeks I put you on 2X, had we stayed with X, you might have gotten the symptom relief you're looking for. 2X, you might be lulled into thinking, is actually needed when in fact it might not be.
The older children too, if you move too quickly, there's a problem around self-efficacy then. They're attributing any kind of progress just to medication and not to something like that.
So the point was that if you move to higher doses too quickly, that one could think that my effect is from the medicine, not from the hard work I'm doing. And I don't know if it's actually different at older ages, but it's something we want to be aware of, both in working with our psychiatry and medical colleagues, and for us as the therapists and for parents, but making sure kids feel that what they're doing is what's creating the change.
And I saw some research a good number of years ago, but it was on children with OCD. And one of the things that they were finding at that point in time is that if the medications were increased too quickly, or even sometimes medications with certain children, that their level of anxiety dropped to 0, so their effort dropped to 0. Whereas if they had like a moderate level, then they would try. But
So if the medicine, the point was, if medicine blocks out all the anxiety, they may not think that they have to do any behavioral work. Interesting point. Some particulars about Zoloft. Again, this is more interesting from a handout point of view because none of us are prescribers. I'm not. And you're not. Parents worry about side effects, and most of the side effects they worry about are incredibly unlikely to happen to their kids. But as therapists, whether we are on the psychiatry end of this or the behavioral end of this, we need to be respectful and mindful of what people are worried about. What is possible is different than what is likely. The most likely thing for a young child to have happen is that they get overly disinhibited. So they start out as inhibited, and then they ramp up too quickly to be disinhibited. So one of my favorite kids, actually the kid that we're presenting next week at the behavior therapy meetings, when she was on her early dose of medicine, she went around yelling the name of her therapist in our office. Therapist looks a lot like you. Christina, Christina, Christina. This kid with selective mutism. We couldn't shut her up from yelling, Christina, Christina. But interestingly, while she was overly disinhibited in our clinic, she wasn't overly disinhibited in school, which is where we needed the effect to be. So that's how, je ne sais quoi, that's how subtle the differences can be. So dose response can be specific to the situation, because we know from our work behaviorally that different situations have different degrees of difficulty. That's why we start out in the tabula rasa of an office that's not contaminated. So we could tolerate the disinhibition in our clinic. We could tolerate the disinhibition in our intensive group program, knowing that she was appropriately disinhibited in the classroom setting. It's a very subtle, interesting kind of difference. What parents are afraid of if they start Googling what happens to kids who take Prozac is they read about kids who had increases in suicidal ideation if they were teenagers being treated for depression. In fact, there wasn't an increase, by the way, in suicidal behavior. There was a slight increase that was not statistically significant in suicidal thoughts, passive suicidal ideation, in a group of kids who was already heavily depressed and more prone to suicidal ideation. So those concerns, you can't just tell parents, don't worry about that. You have to educate them how to use the internet, how to get information that makes sense. We talked just now about activation or disinhibition. You can get physical restlessness, you can get mental restlessness, you can get, it's not actually hyperactivity like ADHD, it's being more impulsive. And we also described as disinhibition, which we talked about. Not uncommon, shortly after starting a dose, you might see it. It's dose related. It's completely reversible, meaning if it really is a deal breaker, when you stop the medicine, the disinhibition goes away. And that there's no long-term predictor about being disinhibited or being an early responder with side effects. There's some potential GI symptoms that physicians will go over, and people will vary depending on their level of experience treating this, depending whether they're psychiatrists or other medical colleagues, how quickly they'll go for intervals to increase. This is a fairly aggressive rate, and many people are not willing to go that quickly. This is a typical range that kids will end up with, but I've had as many kids below this as I've had above it. It's kind of like a normal distribution. Some respond to 10. I have probably in the top 5 most impaired kids I ever worked with, meaning a kid who stopped talking to one of both parents, who was on 80 and is now, I think, about to be discontinued altogether a bunch of years later. A kid who was in was in treatment for both SM and conduct problems as a preschooler in a self-contained class, so a pretty psychiatrically challenged kid who ended up being in one of our Hero Voices panel at my last job, so he's been able to talk in front of a whole group of parents. His parents said, please don't talk about the medication. Well, I decided, I wasn't the moderator, and I just decided I'm not saying anything. I'll let it go where it goes. He talked fine about his medication. He wished he wanted to be off it, and they waited till the appropriate time. This is, so this is interesting. This is the guy that I was talking about before who might treat some kids without medicine, without behavior therapy. And although it's a very small sample, what you see here is what we would call an age-related phenomenon, where younger kids are responding better to the medicine than older kids. But this is sort of apples and oranges, because these older kids have been impaired with this disorder a lot longer than those younger kids. But you do see some trend of the younger kids. This is the level of improvement. So you see your older guys are all getting improvement scores of 1, whereas your younger guys are getting the improvement scores mostly of 2s and 3s with 1, that's there. Terrific psychiatrist named Jim McCracken at UCLA was asked at a conference that I attended years ago, how long do you keep kids on medicine? And I thought he gave the smartest answer that I've used ever since. I've been using this answer forever, which is that you want to get kids through 1 year's life cycle of events. 1 end of year party at school, 1 reintroduction to school, 1 birthday party, 1 Hanukkah, Christmas, Kwanzaa, whatever you celebrate, 1 visit with the intrusive uncle from Des Moines, 1 recital, one of everything. Do you have an intrusive uncle from Des Moines? No. 1 recital, 1 of everything. And frankly, when parents see their kids doing better, they're in less of a hurry to get them off than that discussion would lead you to think when you first start having it at the beginning of treatment. Very few kids need to stay on these forever, but there's a subset of people who are just hardwired to need to stay on medicine. And there's no way of knowing at the beginning of this how that works out. And that's sort of a different focus than today's talk. But what I tell parents is, let's look how your kid is doing, and then you make whatever decision you want, because you can take them off whenever you want. People tend to go in stages coming off as they do going on, trying to pick least vulnerable times, which differs in the life cycle of a family. And so this is what I actually said before, so I'm not going to spend a lot of time. But I think we have a role of helping parents to become educated consumers. I literally will sit at a computer with my parents and go through different websites and different listservs and different Facebook groups and talk about the information I'm seeing and how I respond to it, so that they can get a sense how to think like me. Not that thinking like me is necessarily the right way to think, but if you're coming to me, I guess you want to learn how I think. I don't know. But I think we can educate people how to use the internet, because if there wasn't an internet, people wouldn't find ATS and they wouldn't find me. So we like the internet, and it has lots of good things, but it also has some dangerous things. So the conversation that we had really boils down to this. It's if you're gonna tell me that you're nervous about medicine, that I'm recommending you consider AMAC. Again, I'm not a psychologist, not a physician, so I'm not recommending a medicine or medicating. Then if you're going to talk with me about the downside of medicating, then I need to talk with you about the downside of not medicating. And so it really boils down to this 2x2 table. So we talk about the pros of behavioral only. We talk about the cons of behavioral only. We're having this discussion again because it doesn't seem like your kiddo is responding quickly enough, even though you tell me you're doing an exposure a day. We just did a 90-minute session where they hit all the marks here on the session, but it's not translating outside. We talk about the pros of combined treatment, both in terms of data and our experience. When I give information to families, I try to be very clear whether I'm doing it from a research base or just a clinical base or some combination. When you do that, and this is more for our graduate students here, when you identify what's from a research base and what's from a clinical base, it gives, as it should, more weight to what you're saying from a research base. But sometimes you don't have a research base to draw from. So you go on your clinical wisdom and the collective wisdom of those who went before you. And the cons of combined treatment. So this discussion ends up being something you start early in the process, and you may not need to revisit. If I had to estimate what percentage of patients that in our practice and other practices end up on combined treatment, I'd probably say in the 35–40% range at this point, and it used to be a much lower percentage, probably 25% when I started out, 2002. So I think there's been a significant increase. I don't think it's that kids are sicker. I think it's that we're doing a better job getting effective treatment to kids. Questions, comments? Yes?
Is increased anxiety considered a nuisance side effect?
Is increased anxiety considered a nuisance side effect is the question. Do you have a specific example?
Yeah, we started on Prozac, and by her 13th dose.
13th dose.
Dose.
Oh,
I
not
almost-
13th increase. 13th.
No, yeah, just dose. I was feeling over my dead body, was I going to give her another dose? Because I just saw it escalating. But was that just something I needed to work through as a nuisance side effect? Or was it good to consider another medication?
It's a good question, and one that, for two reasons, I wouldn't give you a direct answer on. One is not knowing the child, and the other not being a physician. But that's the point, you're 2 weeks in, that's the point at which you're having that discussion of, do we try and get through it, do we decrease, do we increase, or do we switch to something else? For most of the people I know, they will do something with the dose within that medicine at a 2-week point before they'll jump ship on that first one and move on to something else. They might back off and go at a slower rate, but most people would probably not jump ship on that one at 13 doses, because that's just under, you mean almost 2 weeks, right? What dose of what medicine?
It was Prozac.
And what dose?
I think we were at 5 milligrams,
So 5 milligrams would be higher for a young child?
9.
So that would be a starting dose for a lot of people. I was going to say, if you told me 10 milligrams for a 4-year-old, I'd say a lot of people start at 2 milligrams. They'll start at 0.4 milliliters, but that's not an unreasonable. That's not an unusual starting point. So it's sort of in a gray area.
I remember during our adventure camp training, Carmen mentioned this interesting research that I hadn't heard of before, looking at kids with SM and kids with SM and social anxiety, and how I don't remember which one was higher, but they have different levels of physiological reactivity, sex suggesting some sort of biological differences. And so with that in mind, I'm wondering if there's any research out there or thoughts about the effectiveness of medication on kids with selective mutism versus selective mutism and social anxiety.
So restating that question, my guess is she's referring to Deb Vidal and Grinnell's research. So some interesting research has been done on physiological arousal, comparing kids with SM to kids with other anxiety problems.
I think it was comorbid SM social anxiety, and I think it was that kiddos with SM only become less physiologically reactive when they're doing something in a social setting because they know that they can just not speak, and so that's already a behavior in place that they then.
So I'm not familiar with which study you're talking about, so I don't want to speak.
And I could
to
be
it.
wrong too. It was just something that I
Could be right.
remember.
But I'll tell you this, that when we look at the kids with SM and we say to them, "Hi, sweetie, what grade are you going into?" What do you see?
They look aroused, like
To
nervous.
you, they look around.
Well, I think that kind of wide-eyed.
You see the wide-eyed.
Mhm.
I think more often what I see is that they're better at ignoring me than I am at
Okay.
knowing what to do with them. By the time they're being asked that question again, they've practiced not responding so many times, they're really, really good at it. So you actually see physiologically often a flattened response, physically and physiologically, a sort of flattened response, a Zen response, because they've practiced it so many times.
Right. They know that they can just not say anything, and that person's just gonna.
I don't know if they know they cannot say anything. I know that this has been the response that they've learned.
Right.
When I was a needle phobic, I didn't think to myself, if I put up a stink, they'll back off and they won't try and poke me. I just got in that situation, put up a stink, and they gave up on trying to poke me unless it was absolutely necessary.
Right.
So I don't know how much volition goes into it. I know it's an overlearned physiological response, and that they're really good. If you're not very practiced at the response, here's what it will look like. I stayed with somebody this week, and she was describing that her 10-year-old daughter she doesn't have SM, but she's got some social anxiety, so she doesn't say hi to the doorman anymore. And in New York City, the doorman is combination babysitter, uncle, best friend, part-time police officer. It's a very unusual relationship.
Psychologist.
It's really a very interesting relationship. So imagine every day you come up the elevator and don't say hello to somebody. Now, again, the kid doesn't have SM, but she avoids, and so she ekes out just a wave and so the mom was telling me this just a couple of nights ago. So I said to my daughter on the way to school, so what's with that? Like, why? It's off limits. I've told you it's off limits. We're not going there. Now that's a 10-year-old who's very assertive, who's able to tell her parent, I'm going to punish you for trying to have that conversation with me. It's going to be a negative aversive experience for you, so back off. But our kids, when they're 4, 5, 3, they can't say that. But they get better at that Zen response than the adults around them. That's what I think.
I think that's a really good observation in consulting with school districts. There are a lot of 2nd and 3rd graders who I usually say they kind of present flat, quite like your description of almost a Zen type of response. But the way the school responds then is, this kid is not anxious. This is not selective mutism. They're just oppositional,
Right.
and they respond very differently.
So restating what you said for our internet audience, because these kids don't look scared, and we want scared people to look scared, we have to substitute some other attribution as to what they're doing. So the attribution that gets put on them is one of two. Either they're being willful, or they're on the autistic spectrum. Because what defines autism? Impaired verbal communication, impaired social communication, stereotypies, rigidities. So these kids, to the untrained eye, look like they're autistic. Or if they're just flat but not looking autistic, then people assume that they're being oppositional defiant. And so what we do as part of psychoeducation is remind people that when you're oppositional defiant, it's never limited to this one area of not responding to people. It comes out in a host of other areas of things that you do oppositionally. Can you have oppositional defiant disorder in SM? Absolutely. Love treating those kids. The first kid I treated that I said went up to 80 milligrams had that combination. The referral I got while I was on the plane yesterday, I can't wait to talk to this family because this kid apparently has both. So it's really interesting what attributions are made. If you're a child of color or other low SES, non-white, male, upper middle class family, your kid is likely not to get the benefit of the doubt. So kids of color and poor kids are more likely to be classified on the spectrum because these kids look like they're not well related. And of course, the history taking is the most important thing that we do to find out the variations, because you can't be autistic only in certain situations. You carry that with you everywhere. So in terms of differential diagnosis, that's not that hard for us to make. But you deal with a lot of schools, and there's a lot of psychoeducation that goes on with that.
Well, since you brought up the autism thing, that is one of the things that in the last 5 years, probably the last 10 years, there's an explosion in the school districts in terms of identifying autistic children. But it's the kids, although in the DSM-4 would be Asperger's, DSM-5 is on the spectrum now. One of the things that I see occurring a lot more frequently is kids who, it's usually they're a little bit older when they're referred for selective mutism, but underlying that is really some lot of autistic features. Whether they meet that diagnosis or not is another issue. Even aside from selective mutism, the number of children and adolescents showing spectrum features has really exploded in DuPage County. So much so that we have redeveloped whole new programs for them. But that does make treatment, though, around that selective mutism. And exactly like what you said, they may have some spectrum features. And again, they won't necessarily show the features of not talking, but they show the features of very rigid, inflexible thinking, perseverating, misreading people. But at the same time, they can talk at home, but not talk at school. That really, and the numbers are really increasing. There's a couple of problems. One is first diagnostically, and then the second thing is really treatment. How do you approach some of those kids with because that the selective mutism.
Let me kind of summarize. You get kids with comorbid
Yes.
SM and other things. The comorbid could be that they are on the spectrum, but that's fine. That's not a rule out.
Right.
It just then lets me know what's their behavior in this setting, what's their behavior in that setting. I'm not primarily treating their autistic features or disorder, but I know what the delta is between how they are in one setting versus another, so I know what I'm shooting for as opposed to shooting for within normal limits functioning. And the same is true with some other comorbidities. I'm looking at the time and mindful that we have some other great things on the program this morning. So I think I'll stop. Point people to our website for more information. And Carmen, you'll be giving information about your website as well, I trust. But we love to hear from folks, and thank you for your attention.